Hello everyone, my name is Magdy and thank you for the opportunity to present our work. Our study is titled The Long-Term Endoscopic Evaluation Following Sleeve Gastrectomy. I have nothing to disclose. The sleeve gastrectomy is the most commonly performed bariatric procedure worldwide, and the complications of stenosis, leak, and GERD are well documented. However, two entities which have grown in terms of their increasing concern are the development of intra-thoracic gastric migration and Barrett's esophagus. Now, there's conflicting evidence in the literature about the significance of these two entities, and that's what's generated a lot of interest for us to embark on this study. We performed a retrospective analysis of patients who underwent a sleeve gastrectomy between January 2012 and December 2013. And we picked this period of time because we have at least 6 years of follow-up. 406 patients underwent a sleeve during that period, and these patients were contacted to see whether they'd be interested in undergoing a gastroscopy to look for evidence of reflux disease, esophagitis, Barrett's esophagus, or migration of their sleeve. And patients that were excluded were those who underwent revision procedures or had a previous gastroscopy during that follow-up period. 335 patients were deemed appropriate to undergo the study, of which 103 accepted. However, only 92 patients actually underwent the gastroscopy by the same bariatric endoscopist. We excluded any patient that had revision procedures, whether that was for reflux disease or complications related to their original sleeve gastrectomy. Patients were also excluded if they had a endoscopy within 3 years of the study or had a contraindication to conscious sedation to undergo that endoscopy. In terms of our demographics of our cohort, the mean age was 44 years old. We had a roughly 1/3 to 2/3 male to female ratio. The mean BMI prior to surgery was almost 50, and the mean BMI at 6 years was 36. We had a mean follow-up period of 6 years with a percentage excess weight loss of roughly 53%. And we chose a definition of weight regain as weight of greater than 25% of excess weight loss that was regained during that period. In terms of comorbidities, there were the classic obesity-related comorbidities of reflux disease, sleep apnea, hypertension, type 2 diabetes, and dyslipidemia in our cohort. In terms of the actual surgical procedure that the patients underwent, 80 of those were laparoscopic sleeve gastrectomies. 7 of them were laparoscopic sleeve gastrectomy with concurrent band removal, and 5 patients underwent a sleeve gastrectomy with concurrent hiatal hernia repair. In terms of results, all patients went the GERD health questionnaire, health-related quality of life questionnaire. And what's concerning is that 55% of patients at 6 years had at least once a week episodes of heartburn or regurgitation. Even more concerning is that roughly 31% of patients had obstructive symptoms at least once a week, whether that be vomiting or dysphagia at 6 years post their sleeve gastrectomy. Endoscopically, 38% of our patients had endoscopic evidence of esophagitis. And when we subclassified the esophagitis according to the LA classification, 62% had grade A esophagitis, 28% had grade B esophagitis, and 8.6% had grade C esophagitis. Fortunately, there was no evidence of grade D esophagitis. When we looked at esophagitis as consistent with the literature, what you find is that 49% of patients had GERD symptoms but no evidence of esophagitis, and 59% of patients with grade A esophagitis had GERD symptoms. So this is consistent with the known data and literature, which shows that GERD symptoms are not reliable indicators for the presence or absence of endoscopic evidence of esophagitis. Even more concerning is that despite 36% of patients being compliant with their PPI, they still developed grade A esophagitis, and 50% of grade B esophagitis patients were still compliant with their PPIs. So like GERD symptoms, PPI is not a reliable indicator of those that will or will not develop esophagitis. In terms of Z-line migration, what we found is 63% of patients had evidence of Z-line migration. And when we quantified the size of the hiatal hernia, 74% of patients had a less than 2 centimeter hiatal hernia, and 25, or roughly a quarter of our patients, had a formal definition of a hiatal hernia greater than 2 centimeters at 6 years post-operatively. Now, depending on the findings of the endoscopy, we would prescribe patients on PPI, and that was seen in 22.5% of patients. What you see here in this graph is that 66% of patients at 6 years postoperatively required PPI, whether we instituted it following the endoscopy or the patients were already undertaking PPIs for symptomatic reflux disease. But overall, 2/3 of patients who had a sleeve at 6 years were on PPI medication. In terms of Barrett's esophagus, 11 patients had endoscopic evidence of Barrett's with the salmon-colored tongue of mucosa consistent with endoscopic Barrett's, confirmed histologically with evidence of Barrett's histologically. However, the length of Barrett's esophagus was quite different. So 5 patients had less than 1 centimeter evidence of Barrett's, 2 patients had 1 centimeter segment, and 4 patients had 2 centimeters or greater evidence of Barrett's esophagus. Now the question arises, why were we biopsying patients who had less than 1 centimeter segment of Barrett's? And the decision by the endoscopist was the fact that these are a different subset of patients. They're obese patients who have undergone a laparoscopic sleeve gastrectomy, who have got evidence of Z-line migration, and had endoscopic evidence of Barrett's esophagus, and as such, had biopsies performed. These were not random biopsies that were performed at the cardioesophageal junction. When we look at all these 11 patients who have evidence of Barrett's, fortunately, there are no patients with dysplasia. Now, when you look at the graph, unfortunately, there's no correlation that can be made between the length of the Barrett's esophagus, whether the patients have absence or presence of reflux disease, and whether the type of surgery they underwent, whether it was an isolated sleeve gastrectomy, whether it was a sleeve in conjunction with a hiatal hernia repair. There is no logical conclusions that can be made between these entities. Statistically, we wanted to discover if there was any correlation between different entities and Barrett's, so we performed univariate and multivariate analysis. And we looked at specific criteria that we thought would be positive correlators, in particular weight regain, the intervention, whether it was an isolated sleeve or a sleeve with a hiatal hernia repair, whether there was endoscopic evidence of angulation, whether there was presence or absence of a hiatal hernia and the size of that hiatal hernia, whether the patients fit into the super obese group with a BMI greater than 50, whether the patients were symptomatic of reflux, and whether they were actually on PPI medication or not. And despite univariate and multivariate analysis, there is no clinically significant correlation between these entities. Likewise, for esophagitis, the same entities were studied, and once again, there is no clinically or statistically significant correlation between these entities. This study does have significant limitations. It's a retrospective study. It's a traditional cohort of patients where sleeve gastrectomy was being performed indeterminate of patient symptoms. And only 13% of our patients actually agreed to have an endoscopy. Furthermore, there's a selection bias in the sense that these patients are those that were most likely to be symptomatic and embark in our study. Unfortunately, given the traditional historic indications, there was no preoperative endoscopy that we could correlate the postoperative endoscopic findings to. What is significant, however, from our study is that there are 3 major entities: esophagitis, Barrett's, and hiatal hernias. And there's quite a significant clinical incidence of all 3 entities. What are the implications of these 3 entities? However, we're uncertain. And ideally, what would happen is that in our next cohort of patients is that we compare preoperative endoscopies to these postoperative endoscopies and see if there is a clinically significant correlation. The length of the Barrett's esophagus and whether there's dysplastic changes or not is once again uncertain, and whether there were developments of malignant disease that will arise is also uncertain. What is quite significant, however, from our study is that those 3 entities do exist, and they are consistent with known guidelines, consensus guidelines from both ASNBS and the IFSO position statement, which advocate for postoperative endoscopy in patients that undergo sleeve gastrectomies because of these entities. Ideally, we would correlate all these symptoms with gastroscopies to be able to draw meaningful conclusions, which at present we're unable to do. Thank you for your time.